patient assessment. Please give them a hand.
Hello. All right, so there was this one time where I bumped into a mannequin, and I said, "Oh, sorry." And then I said, "Oh, I thought you were a person." And then I realized that I was still talking to a mannequin. So now I have a question for you guys as students. Please raise your hands. How many of you feel better when assessing a mannequin? All right, and now how many of you as students feel better when assessing a live patient actor? Okay, so many of you expressed that you have a greater comfort level when assessing a live patient actor. So my name is Martha Helmers, presenting with Kayla Dunn, Samantha Kirschner, Greg Bowie, and Presley Smith. A paramedic student's training is composed of many aspects of education, including in-class lectures, written examinations, and clinical scenarios that are meant to simulate pre-hospital care. Mannequins, as well as live patient actors used to simulate the real patient, also known as standardized patients, are used in the Fanshawe College Paramedic program. Mannequins are used for most high-fidelity scenarios on a critical patient, while standardized patients are used occasionally in some simulations to provide paramedic students practical practice interacting with patients. It is assumed that the experience performing these high-fidelity patient assessments on mannequin will be easily transferable when performing these assessments on patients in the field. Our study aimed to investigate how well we as students are trained and prepared to handle these patients in the field after we graduate, and to determine whether greater implementation of these standardized patients should be used to help first-year paramedic students perform a thorough primary assessment that reflects practice needed for their future careers. Now we will hear Kayla talk over our literature review.
Okay, so the purpose of this literature review was to view articles that included research on students that have been involved in training for their primary assessment while using mannequins versus a standardized patient when practicing for patient care. The question being asked was, do first-year paramedic students' ability to perform a thorough primary assessment differ between a mannequin versus a standardized patient? As searches were conducted, it was apparent that there's a very much lack of research in regards specifically to paramedic students with this study. So the first article we looked at was third-year undergraduate nursing students' perceptions of high-fidelity simulation. So 300 nursing students were entered to participate. The participants were asked to fill out an evaluation form and rate their satisfaction when working with high-fidelity simulation. So the students had rated that they had a positive experience when working with high fidelity, as it gained their attention more than just using a regular mannequin. So in the next article, comparison of patient simulation methods used in a physical assessment course. This focused on pharmacy students and whether or not there was any learning or practice differences with a standardized versus a mannequin. The students who were taught on the mannequin felt less satisfied compared to 88% of students who used a standardized patient. They gave their learning experience an extremely satisfied rate, the ones working with a standardized patient. The grades from the study showed that there was no difference, so 93.8% on the mannequin versus 93.5% on the standardized patient. But the students believed that they had a greater learning experience when working with a standardized patient. So the next article, effectiveness of high fidelity simulation for pediatric staff nurse education. So a pre-test and a post-test with a controlled group study was conducted. So only 33 nurses participated in this. The group using high fidelity scored a much higher mark at the 6-month mark compared to the ones using just a regular mannequin. So it just proves that the standardized patient proves more long-term learning than just a mannequin. And then the last article, mannequin or standardized patient. So participants' assessment of 2 training modalities in trauma team simulation. So the study was done on trauma teams in the hospitals who mainly use mannequins for their studies. So 5 hospitals were used in the study. Each team in each hospital did back-to-back scenarios with a standardized versus a regular mannequin. They then filled out an anonymous questionnaire comparing the 2 scenarios in realness versus embarrassment. So the results show that there's not much difference or preference with a mannequin versus a standardized patient when it came to the treatment provided or embarrassment from the staff. Most people, however, did prefer the standardized patient for learning. So in conclusion, the articles reviewed presented the current literature relevant to our study. While literature found did not directly involve paramedic students, there were still other relevant data to support our PICO question. It became apparent that the greater implementation on standardized patients would lead to greater achievements in the paramedic student learning. I'll now pass it over to Sam, who will talk about our methods for our study.
Hi. So our study was focused on first-year paramedic students during their first semester. The scenarios were done during lab class of section A and B. Each lab section, we had the students divided in 2 partners, with one posing as the primary paramedic and the other one as the secondary paramedic. Students were informed that the secondary paramedic was not to do anything until instructed to do so by the primary paramedic, as the purpose of the study was to determine what is missed by the primary paramedic. The pairs then switched primary to secondary to ensure that each got the chance to be the primary at one of the scenarios. We had 2 clinical scenarios going at the same time. Both scenarios were generally unwell. One of the scenarios was done on a standardized patient, while the other one was done on a mannequin. For each of the scenarios, the primary paramedic had 12 minutes to complete their primary assessment. At each station, there was an evaluator marking them on their primary survey. So this is our checklist that the evaluator had. So if the primary paramedic didn't state that they were checking anything that was on their anything on their assessment, then we didn't mark it down. If they weren't going to rule it out, we also marked it if they did or not. So we had 20 participants for the mannequin, and for the standardized patient, we had 24 participants. Okay, and now it's great.
All right, so for our outcome measures, there are a few key parts we wanted to focus on. So the overall performance was based on how thorough the students were with each part of their assessment. So we combined each section to give them an overall score, which combines all these other parts. Airway, breathing, and circulation. So how did the students actually assess these? Were they taken properly? For example, did they actually feel for a pulse point and take the time to assess the rhythm of that pulse that they found and then say that? Or were they just assumed that they had a pulse based on the standardized patient breathing and obviously having a pulse? Life threat assessment. The standardized patient was a female. A lot of the first year students were male. So did that cause any hesitation or avoidance to physically assess the patient? Visualizing the chest, for example, the standardized patient was short of breath. So was there any accessory muscle use? Obviously, the standardized patient had shirt underneath, so there was nothing that would have been inappropriate there, but avoid that altogether because they're not used to dealing with a standardized live patient. History taking, this is the OPQRST and sample. So where the students modifying their questions based on the patient's chief complaint. So where obviously you wouldn't ask somebody what their pain rating is when they're just having difficulty breathing. So instead, were they assessing how many word dyspnea the patient had and letting us know that, or were they leaving that out and missing certain parts? Lastly, the vitals. For this assessment, the students were told ahead of time that they could delegate any specific vitals that they wanted their competent partner to complete. However, if they did specifically ask that person to get that vital or obtain the vital themselves, then it wouldn't be given. So next I'm going to talk about the data analysis. So since we had to modify our data collection due to limited time, our analysis had to change as well. So we initially were planning on running each student through both scenarios with the mannequin and standardized patient. And we were going to then have them run through the scenarios again the following weeks. And so instead, because of limited time, what we had to do is we just analyzed each specific part to show a difference between if they completed it or did not complete that assessment. And while all parts and sections of the primary assessment were important, we focused mostly on showing a difference just between the mannequin and standardized patient and not between each part of the primary survey. So what we found was the mannequin group's overall performance of completion, shown on the slide, was 64.16%, while the standardized patient's overall performance of completion was 50.7%. So to get these results, we used the t-tables to find out our p-values, and the p-values would determine the significance of our null hypothesis. So, and now we're going to look further into our results with the next section here.
So one thing that we found kind of interesting is every time we asked the question, like we did at the beginning, who's more comfortable assessing a human patient? Most of you raised your hands. I think there was only 2 that didn't. However, looking at all of our data, everybody did better on a mannequin every single time when we analyzed it. So these values up here on the screen, 64 to 50, don't seem like a huge difference. But when we broke it up into components of the primary survey, that's where we found the biggest changes. So let's start at the beginning. If you look at this graph, the blue bars represent the assessments that were done on a mannequin, and the pink are on the standardized patients. So in the first part of the graph, on the mannequin, students completed airway, breathing, and circulation checks. So for this, where they are in their learning in first semester, is they are supposed to verbalize everything. So when they walk in, they say, you know, my patient has a patent airway, bilateral chest rise. That's what we were looking for, and if they said that, they got the check mark. If they just assumed we knew that, they did not. So 83% of people did that on a mannequin, whereas only 75 did on a standardized patient. Looking at the second set of data there, we see the results for getting vitals. What we were looking for is a basic set of vitals, so we classified that completed if they got a minimum of a heart rate, a blood pressure, and a respiratory rate. A lot of the time they delegated that to their partner, but if they just said, get me vitals, and didn't specify, it wasn't counted. We wanted to hear them say what they wanted. So 55% of the students completed these 3 vitals when they were assessing a mannequin, and only 29% completed this when they were assessing a standardized patient. If you look at the next bars, we are talking about life threat assessments. So students were marked if they either physically did it, so did a wet check, looked for obvious trauma, or they could just rule it out and say, based on my patient, I don't need to do that, and that was fine as well. 70% completed this for a mannequin, and 33% on a standardized patient. So the last piece of data up there is where we figured that we would see the biggest change, is the communication, or in this case, these numbers come from the history taking. So we were looking at the sample and the OPQRST. So when we looked at the communication, when you're doing a mannequin scenario in a lab class, you're going to ask questions and you're going to take your history. Typically, the person running the scenario is going to give you a very pointed answer, and they don't really go much off track. They answer your question and then they kind of stop and wait for you to proceed. Whereas when you're assessing a human or you're out on your actual clinical placements, these generate conversations, right? You don't necessarily go one by one and cross everything off of your list because you get sidetracked or people start telling you something else and it can really throw you off based on where you are. So for the mannequin, 50% of the time people took a full history and hit all of those checks, and only 33% on a standard patient. So when we analyzed this further using t-tables, this is what we saw. So we were looking for a 95% confidence interval, which would be a p-value on the third row there, less than 0.05. As you can see, we didn't get that, and we'll explain why coming up here. So when our study was originally designed, we had intended to spend 4 lab classes with the first year students. We wanted to run everybody through both scenarios and then look, how did you individually do on your standardized patient, and then how did you do on the mannequin, and are there trends there? Because of the shortened semester, we didn't have access to the first years for that long, so we had to modify. That's why we ended up just averaging everything out and looking at general trends within the class. We could have went back in this semester and done it again with the opposite type of patient, and that would have put people through both. But we figured that the education bias that would have existed in that group wouldn't have worked because they've learned so much in that 2 months, and it would have changed everything and skewed all of our results. So we left it with our one time, they each completed one scenario. Which the implication of that is our sample size was very small. We had 20 people in the mannequins and 24 in the standardized patients. So going back to our original hypothesis, we thought that people would feel better and do better assessing a mannequin, not a standardized patient, because that's what first year lab you're typically assessing on. They haven't had the experience, or they've had very limited experience out on their rideouts in the field. So what we found in our first year, and why the study kind of came to be, was that we were doing a lot of mannequin assessments, and then in first year, when you're brand new to the field and you're jumping in on your rideouts, it's really different. You have no issue, right, like exposing the chest of a mannequin, but then when you get out there, you're really hesitant in front of, say, a female patient that's complaining of chest pain, and you're trying to auscultate, and you're like, I'm just gonna go over the shirt. It's not the same thing. So as much confidence as you have in the classroom assessing a mannequin, it doesn't always translate out in the field, and sometimes you kind of knock yourself down a peg and you think you don't know it when you actually do. So we figured that that disconnect and kind of the learning curve that has to be tackled in first year is a big part of why sometimes the awkwardness comes out. So although we found trends in our original data, we couldn't really say much in terms of confidence. Our P intervals were not under 0.05. So our trends do suggest that people do better on a mannequin, but we can't say that's necessarily universal at this point in time. So I'll give it back to Martha to kind of wrap it up.
Thank you, Presley. So, as Presley explained, with our statistical analysis, we found that there was no significant difference in the students' ability to perform their primary assessment on the different types of patients. Therefore, our study disproves our hypothesis. While this is true, we believe that this is due to the drastic decrease in our sample size. We believe that a recruitment of more students and involving more colleges could produce significant results in a future study. Thank you for your participation and attention. That concludes our presentation, and we will now open the floor to your questions.
Hi there, Scott Reynolds, Middlesex, London, Paramedic Service. Apologies, could you go back to what your original hypothesis was? You were trying to say that you would be better on a patient or better on the mannequin?
So we originally set out to say, because first year students are used to assessing on a mannequin, that they would do better and be more confident in front of a mannequin as opposed to a standardized patient, because they aren't used to that yet.
Okay. The mannequin that you used, were these the high fidelity mannequins that you can feel, palpate a pulse and take a blood pressure on? No,
they were not. So we have those in the school. However, typically in our lab class, we use just a standard mannequin that, you know, is hard to move around and has no sort of it's a piece of plastic sitting on the floor. So since we use that in lab, that's what we used in these scenarios, and then we used Martha as a patient for the standardized.
Very good. Thank you.
As an educator and somebody who watches you do these scenarios, I'm really fascinated by what you've found, because I think that us watching you assess a patient, be able to verbalize all that thing, all that stuff confirms whether or not you do know the steps and have the ability to do those assessments and recall sort of these checklists, etc. Right? My question is, do you think that enrolling standardized patients in first semester is important, or later on in the, in second or third semester? Because my concern from what you've found is that students maybe necessarily aren't verbalizing, that they can go through these checklists in a primary survey, etc. So to be able to evaluate you for competency in that would be difficult on a standardized patient, because what you're showing is that people aren't necessarily doing that. They're looking at the patient and they're, using what they can see and what they can hear and et cetera, and, processing all that information. Or do you think that the issue here is a comfort level with assessing real people? Like, is the benefit, my question, sorry, it's kind of a convoluted.
No, that's okay, I get what you're saying.
Yeah, like, is the benefit to start in first semester to get comfortable, right? Or is it to slowly roll it in later in your education? Because from what you're showing, it can be difficult for us to evaluate you if this is how students are going to go through these scenarios without all that verbiage.
Yeah, so when we kind of originally talked about this, we were like, well, if we find results that are statistically significant, saying that people are doing better on mannequins, maybe they should implement more in lab class, that more of the standardized, because that way you get used to it and it's not like a culture shock when you go out into the actual placement. So we were kind of looking for that, like, should we implement them? When should they be implemented? Since we didn't have a big enough sample size and we didn't get statistical significance, that's kind of where we're recommending future research to come from. Because it would be interesting to see that. Although I think from all of our opinions, if you started with it at the beginning, then you wouldn't have to make that adjustment. I think that's where we kind of all stand on that, is like, if we started from first year and you just learned your primary on a standardized patient to begin with, you wouldn't ever have to make that adjustment. That kind of takes a little bit of time. All right, thank you.